So we move on to syndesmotic injuries. Ankle, as all of you know, is a very, very uncompromising joint, and even a millimeter of shift, if it persists because of any reason, can lead to a disaster. And there's no salvage. Once the post-traumatic arthritis begins, there's no salvage left at all. So syndesmotic injuries are basically of two types. They are associated with fractures around the ankle to the extent of about 25%, mostly Weber type B and C, and they can be isolated syndesmotic injuries as seen in sportsmen. About 20% of them present like that. What is important to remember is about 42% increase in the contact pressure if the widening of the syndesmosis is as less as 1 millimeter. So if you don't diagnose or treat them properly, then you are going to land up into trouble. And definitely the sporting career of that patient will be in jeopardy. All of us know the anatomy of syndesmosis and the fact that the stability depends on three ligaments, mainly the anterior and the posterior tibiofibular ligaments and the interosseous tibiofibular ligament. It is the posterior tibiofibular ligament which is more important, and just below that there is a fourth ligament which is the transverse ligament, which is nothing but a fibrocartilaginous condensation, something like a labrum in the shoulder. So the PITFL and the transverse ligament together provide the 50% strength and stability of the syndesmosis. So it is the posterior structures which are more important, and we'll see in a moment how to handle them. So needless to say that if you have an X-ray of an ankle fracture like this, everything is going to be disrupted and needs reconstruction. How do you diagnose isolated syndesmotic injuries? They are not really apparent on X-rays, and it is the clinical diagnosis, pain over the anterolateral aspect, the squeeze test, which is more specific, single leg hop test or the Cotton's test, and the dorsiflexion external rotation test. So all these are clinical tests which are given in any clinical textbook, which should prompt you towards appropriate radiological investigations, and most of the routine X-rays would not show anything, but the most important investigation in all this would be the MRI, which will clearly show the disruption of the ligament. Traditionally, we have been taking the Mortise view in which if there is a medial joint space widening and a tibiofibular overlap which is less than 1 millimeter, then it is a syndesmotic injury. Three indices which are used to or were used to diagnose this: the tibiofibular clear space, the tibiofibular overlap, and the medial clear space. So the most of these radiological indices have been used in the past, but then if you see today, the MRI has surpassed most of these in radiological or X-ray indices. It's quite obvious in a fracture. If the fracture line begins 7 millimeter proximal to the ankle joint with a medial clear space more than 4 millimeters, then definitely there is a syndesmotic injury which needs to be handled. Stress views no longer taken. It is the MRI. Now, if you see this X-ray on the left side, the tibiofibular clear space is normal, but the MRI is showing a syndesmotic ligament injury. So also about the overlap, this is normal, but the MRI shows a high grade. So 100% sensitivity for the syndesmotic injuries is seen only in MRI. Treatment of isolated syndesmotic injuries, quite simple. If not badly displaced or MRI does not show a complete disruption of all the three ligaments, you can treat them non-operatively by casting for 3 weeks and bracing for 3 further weeks. Some surgeons have tried PRP injections, especially those sportsmen who want to return to sports early, or periligamentous steroids. I'll not go into posterior malleolus because it has been nicely covered by Dr. Shah. Needless to say that it has a role in fixing, and almost all posterior malleoli are now being fixed with whatever modalities available. Important another fracture is the Mason-Lewis fracture, where you don't have anything in the ankle but a fractured fibula up there. this is definitely an indication to fix the syndesmosis. So how do you fix it? You can clamp it using a pointed reduction clamp at 15 degrees to the horizontal. You should not fix using a lag screw. It should be a holding screw. How many screws is, there's no consensus on it. You can use 3.5 or 4 mm cancellous full threaded screws, either 2 or 1 4.5 millimeter screws, it does not really matter. 3 cortices or 4 cortices, another controversy. Again, there is no difference in outcomes. A few tips: reduce by palpation. What is more important is perfect reduction of the syndesmosis. So either reduce by opening it anteriorly and palpating the anterior border of the tibia, of the fibula. Clamp at 15 degrees to the horizontal. The screw trajectory from the fibula to the tibia should be about 15 to 20 degrees. Any amount, 2 or 3 screws can be used. Dorsiflexion of the ankle, which has been traditionally taught to us as residents, is not really required. In fact, the recent papers now say that it should not be done. If you are using 4 cortices, then better remove it at 3 months. This was a nice paper by Paul Tonetta, JOT 2016, later on in Injury by Gonzalez, that if you dorsiflex the ankle, in fact, you are causing valgus external rotation and subluxation of the syndesmosis. So it's not required to dorsiflex the ankle when you're fixing the syndesmosis. 2004 paper, 4 cortices are better. 2005 meta-analysis by Mohit Bhandari, 3 cortices are better. Actually, loosening of those screws which is seen will help settling down of the syndesmosis. So instead of this, if this is your situation, then it actually helps settling of the syndesmosis. Another reduction tip: do not hold the heel, because if you are holding the heel, then the talus shifts anteriorly, and along with that, the fibula also shifts. So instead, let the leg hang free, support the calf, and then fix the syndesmosis. This is a diagram showing the screw trajectory. If you put a neutral screw at 0 degrees or neutral clamp at 0 degrees, then you are actually posteriorizing the fibula. At 15 degrees, it reduces very well into the syndesmosis, and at 30 degrees, which has been conventionally taught to us, it can have anterior subluxation of the fibula. Dynamic fixation using tight rope. More and more papers are talking good about it, but there is a question about sagittal plane stability. So we have done a few without any problems. There are certain papers which talk about, this is a very good multicentric RCT, November 15, about dynamic fixation of the syndesmosis, and it is shown to have better results than the screw fixation. Post-op protocol: you can start non-weight bearing, toe touch at 6 weeks, and full weight bearing at 3 months. Open reduction. Should we be doing open reduction? Yes, there is a role of open reduction, because currently the problem with syndesmotic fixation is not the fixation, but the syndesmotic reduction. There is an increasing incidence of malreduction of the syndesmosis. Look at all these papers, 39%, 52%, etc. And all these malreduced syndesmotic fixations will lead to poor outcomes at the end of 2 years. Most of these will be iatrogenic. Malreduction can be of 3 types: translation, that is sagittal and vertical; rotational; and overcompression. There are various causes, improper assessment and technique of the surgeon being the main cause, but then you could have an untreated posterior malleolar fracture, soft tissue interposition in the joint, or an anteverted incisura. So something like this, an untreated posterior malleolus or a flat incisura. This looks well reduced, well fixed. Take a CT scan and see what has happened. So this is one paper which talks about how to assess the reduction on table, and that is by taking a true lateral view and looking at the amount of tibia which comes out of the fibula, the posterior malleolus that comes out of the overlap of the fibula, and replicating that on the injured side. So to conclude, anatomic reconstruction of the fibula in length and rotation is a must, Anatomic reconstruction of the incisura, thereby fixing the posterior malleolus, is again a must. Clamp angle of at 15 degrees, and the screw angle should also be 15 degrees. Isolated, we have talked about some delayed presentations, recent advances, augmenting or ligamentoplasties using peroneus longus and extensor tendon slips have also been described.